Today we're going to discuss the dengue situation in Latin America, which is a bit of a problem, mostly in the late years. It's not longer an sporadic or seasonal issue. It has become a persistent and expanding epidemic with profound health and social economic consequences. This presentation will explore the current epidemiological landscape, the drivers behind the expansion of dengue, and the strategic response that requires across the Latin American region to control and prevent future outbreaks. Dengue is a growing threat for the whole world, but especially for Latin America. Dengue has emerged as one of the fastest growing mosquito-borne viral diseases worldwide, and in Latin America is carrying a particularly heavy burden. Transmission is concentrated in tropical and subtropical areas where the Aedes aegypti thrives, but the geographic range continues to expand to areas not previously known to have dengue or reported dengue. Climate change, rapid urbanization, and increasing population mobility has intensified the transmission dynamics, creating unprecedented pressure on healthcare systems throughout the region. 2024 dengue epidemic marked an unprecedented turning point in Latin America. It has been the most it had been one of the most unprecedented increasing numbers of dengue that we have ever registered on the region. We have registers since 1980, and this has gone over the charts very heavily. More than 12 million cases were reported during that year, and nearly 8,000 deaths were reported across the region, making it the largest outbreak in record. Brazil alone accounted for approximately 83% of all cases in the Americas, expecting the worst dengue epidemic in his history. Countries in the southern hemisphere, especially Argentina, saw a dramatic increase in case numbers, with a fourfold rising compared to 2023 epidemic. The geographic distribution of the serotypes, dengue, it's well present in all the region. There are 18 countries so far in 2025 reporting active dengue serotypes, and the several countries, including Brazil, Colombia, Costa Rica, El Salvador, Mexico, and Panama, are reporting the 4 different serotypes circulating at the same time, with an increased risk of severe disease and major challenges in surveillance, clinical management, and vaccine strategy. What are the drivers of this expansion, of this dengue expansion? There are multiple interconnected factors that are driving the rapid expansion of dengue in Latin America. Unplanned urban growth creates ideal mosquito breeding conditions due to poor water storage and waste management. Rising temperatures and altered rainfall patterns expand mosquito habitat and accelerate viral replication. Increase in travel and migration allows serotypes to spread rapidly across the borders, while growing insecticide resistance in mosquito population reduce the effectiveness of traditional control measures. During most of 2025, between epidemiological weeks 1 to 53, dengue posed a substantial disease burden across Americas. Over 4 million suspected cases were reported. Nevertheless, not even compared to the previous year, but nevertheless an important number, with more than 1.6 million laboratory confirmed infections Although severe dengue represents a small proportion of total cases, these patients accounted for a disposition of or a great share of the mortality. The epidemic surges continue to overwhelm healthcare systems, diverting resources from some essential service to others, highlighting the need to strengthen preparedness for this type of situations. Effective dengue prevention cannot rely solely on the health sector. A coordinated multi-sectoral approach is essential, involving health authorities, environmental services, education systems, and urban planners must be taken in account. Community engagement plays a central role, as the majority of mosquito breeding sites are found in and around homes. Innovative strategies such as the use of Wolbachia-infected mosquito, with further diminishing their population, have shown promising results in reducing transmissions in several Latin American countries. Vaccines are proving to be a very important pillar on the dengue prevention strategy across the Latin American region. Over the past decade, significant progress has been made in vaccine development, leading to the availability of multiple dengue vaccines. These advantages offer opportunity to reduce several severe disease and hospitalization, particularly when vaccination is integrated with vector control and surveillance efforts. Currently, there are three main vaccines that are shaping the regional landscape. Dengvaxia requires 3 doses schedule and shows a moderate effectiveness with a strong protection against hospitalization. Unfortunately, this vaccine requires a previous infections with dengue. So the need to verify the infections is needed previous to vaccination. Odenga offers a 2 regimen with a broad serotype coverage and a long-term protection. It has been estimated 7-year protection is well covered. Most recently, there's a single dose Butantan DV vaccine developed precisely in Brazil that has demonstrated high efficacy against severe disease and represents a major breakthrough, particularly in hard-to-reach populations. Several countries are actively incorporating dengue vaccine to national strategies. Brazil has launched an emergency vaccination effort following its 2024 crisis, and is preparing a large-scale development of the Butantan TB vaccine. Argentina is integrating dengue vaccine into routine programs after experiencing a sharp rate increase last year. And across the region, vaccination strategies are expanding beyond adolescents to include broader age groups, and new evidence of supply becomes available. The global dengue vaccine market is projected to grow from 90 millions in 2025 to 180, almost 200 millions in 2035. Real-world data have confirmed that effectiveness in dengue vaccine under epidemic conditions it's well documented. Studies conducted during 2024 outbreak in Sao Paulo show that Odenga significantly reduced several cases and hospitalizations. Protection was observed across all 4 dengue serotypes, regardless of prior exposure, with evidence of sustained immunity lasting several years. These findings reinforce the role of vaccination as a power tool of outbreak mitigation. Despite progress, important challenges remain. Vaccine supply constraints limit rapid scale-up, particularly during epidemic breaks. Cost remains a barrier in especially low-income countries, and booster strategies may be required to maintain long-term protection. In addition, vaccine hesitancy is in certain communities, especially indigenous communities, highlights an importance in transparent communication and trust building within the public. The introduction of a single-dose vaccine such as Butantan DV offers significant strategic advantages, especially in areas where it's difficult to reach or population that are isolated from the main cities or the main central health units. These vaccines simplify logistics, reduce the needs for multiple clinic visits, and are especially beneficial remote and underserved populations. Integration into national immunization schedules is accelerating, creating opportunities for more equitable and sustainable dengue control. There is an important issue in strengthening the early warning systems, because that is one of the principal areas that is lacking um, uh, a solid response, especially in low-income countries in Latin America. A robust surveillance system is essential for effective development. Strengthening this system and these early warning systems requires a standard control data, enhanced laboratory confirmation, real-time risk assessments, and rapid response mechanisms. Integrating epidemiological data with climate and vector surveillance allows for public health authorities to anticipate outbreaks and allocate resources more effectively. There is no specific antiviral treatment for treatment of dengue. So early recognition is essential, and training healthcare workers to identify warning signs and severe abdominal pain, persistent vomiting, bleeding, and lethargy is essential to diagnose and treat opportunely patients with severe dengue in order to reduce mortality, especially in areas where there's no high complexity of a health system built in. Fluid management remains one of the mainly pillars of the treatment. Appropriate fluid resuscitation is critical during the critical phase to prevent shock and organ failures. Monitoring the outcome is essential. Also, close observation of the hematocrit, platelets, and the vital signs to detect plasma leakage is essential. The WHO has made a huge effort trying to generalize and consolidate the guidelines for clinical management of all arboviruses, and is available at its website, and it consolidates all the latest information and research made, especially taking into account the results of the epidemic of 2024. In conclusion, addressing dengue in Latin America requires a sustained political commitment, increased investment, and coordinated regional action. Stretching collaboration, advancing research, engaging communities, and expanding access to effective vaccines are all essential components of a comprehensive response. The scale of a recent epidemic makes it clear that the time to act is now. before dengue continues to extract even greater toll in these regions.
Can you give us an overview of what happens in children with dengue? Which is your experience? Do you of the clinical presentation in children, or something on mother to child transmission of dengue to share with us?
Yes, we had had an experience, mainly dengue in Central America, which is when I'm from. It has no seasonal behavior. We have dengue the whole year, and we have especially in El Salvador, we have the four serotypes circulating, and we have cases, especially in under 5 children, very difficult to treat. We have seen a pattern, especially in malnourished children, that these children, against all odds, they rarely develop severe dengue. We have seen more severe dengue in obese and overweight children, which can be easily mistaken as not being dehydrated. And the progression usually is between 1 and 2 days from the initiation of the symptoms. Dengue is a very high concern in the Ministry of Health. It's an obligatory notification disease. So all dengue cases are trying to be managed in a second or third level hospital, which we have distributed along the region. Dengue usually we have a very small mortality rate in this year, in 2025, sorry. And it is because of the early warning system. We have to thank that the Ministry of Health has established as a specialist survey in this system for in the electrical record system to identify the 4 major symptoms related to dengue, which are fever, vomited, abdominal pain, and lethargy. These 4 signs are being monitored and asked in every visit when a child presents with these symptoms. It's immediately selected to a triage area where usually the children are tested and for the NS1 antigen, and which is a fastest that relies on answers on the results within 1 hour, which we get to have available 24/7 in most hospitals, which aids a lot in the early detection of dengue in children. Unfortunately, progression has been controlled. We have had not so many cases as in 2024, but we still do have cases mostly in the in winter and when the rains start, and previously to the rain, people gather water and there's a lot of mosquitoes breeding sites, which can be controlled and are actively controlled in the by the Ministry of Health. We do not use or we do not have vaccines available in our country. We don't we don't have the experience with vaccines. We used to have Tembaxia about 4 years ago as a trial, but it didn't progress to our immunization schedule. We are not currently using any vaccines, but we are very interested in this new development of 1 dose of the Butantan vaccine, which is being developed in Brazil, because it requires only 1 dose. Unfortunately, the age for initiation of vaccination is beyond 6 years, and the small population, which is the most affected, cannot be protected. That is especially our situation. We have had no cases reported of vertical transmission of dengue, but there are all other arboviruses like chikungunya and especially Zika, which has had with high documentation of transplantary infections, especially 5 years ago, when we have an outbreak of Zika here in El Salvador. But recently we have had no information. Last year I don't have the data, especially on Zika, but my impression is that we have very small cases, sporadic cases of Zika. We have the.
Oh, sorry, because
No,
we have some questions. So sorry. Go ahead.
no. That's it. That
Okay.
was almost it.
We have a question in the chat. We have two questions. One from Desiree, who thank you for your wonderful presentation. And Desiree asks you which populations are eligible for vaccination. Are pregnant women and children eligible? You say something about, but are
Yes.
they, and which is the mortality, morbidity rates among pregnant women?
Pregnant women are a high risk population because of their conditions. The Mvaxia is the only vaccines that we did have experience. The age of vaccination was 9 years and over until 65, I believe. But it was required to have experienced disease. So in some situation, a test for immunological markers were needed previous to vaccination. That made very difficult to vaccinate or to develop a rollout plan for vaccination. But 9 years and older were the recommendation from the manufacturer. We have some experience with vaccination over 5 with good results. Not the most important marker for this vaccine was the reduction of hospitalization related to dengue or severe dengue. And no experience on vaccinating pregnant women with the dengue vaccine, although some studies consider them as a target population for vaccination. But we do not have any experience on vaccination vaccine on pregnant women.
Wonderful for discussion. Christina Hoffer from Brazil, she asked you if in European traveling children, should we consider the immunization? And if yes, which one?
Sorry, what was the question
In
again?
European traveling children, should we consider
Okay.
immunization? And if yes, which one? Christina, you can also intervene.
Yes, vaccination for European children. Well, there are a small number of countries that include outside Latin America and Asia, I think. They recommends vaccine for traveling into regions, but especially in regions like South America, there are certain virus-borne diseases, especially like yellow fever and dengue, which is considered as a vaccination prevention for travelers from other regions. But I'm not acquainted with regions and what vaccines are recommended.
Thank you very much.
Dengue.
Oh, sorry. Yeah.
Sorry, it's all right. It's just for dengue that I was thinking about. Do you think the Butantan would be a good vaccine for traveling children from outside Europe for endemic regions?
Mostly because I think the Butantan, it will be a great option for everybody because for because of the easy the just a single dose needed for and a very good outcome in diminishing severe disease and hospitalization. Also, a long time protection. It would be great to have it, but as for now, it is only being used as in Brazil, which has been developed, and there I think there is no and not a clear recommendation to use outside the Brazil. I don't know if PAHO or WHO has considered to include it in its recommendation so far. But I think it will be a good option for travelers traveling to endemic areas.
So I will give you a talk mostly on from an epidemiologic and research clinic perspective. Even I'm formerly a pediatrician working in the NICU and maternity ward at the time of the epidemic. Focused on congenital chikungunya as a novel treat of child development and neurodevelopment. I have no conflict in interest with this talk, except I'm a consultant for Takeda and Valneva, and I'm leading the Path 4 trial on ICCIC vaccine in Réunion, which is currently in development. My talk will be divided on, I will present two weak parts. One on the background knowledge on chikungunya and congenital transmission of arboviruses before 2006, and I will focus mostly on the lessons from the Réunionnais epidemic and Brazilian experience that come years after, and I will finish my talk with our research findings on the long-term neurodevelopmental outcomes of Réunionnais children, which are who have now come to 15, 60 years old. Chikungunya is mostly observed as an epidemic arboviruses. It is very different than from dengue, except in the situation where there are selvatic cycle and animal reservoir, like in Brazil or in Asia or East Africa. But in most part of the world, it comes as an epidemic pathogen with a lapse of about 15 or 20 years between epidemics. It belongs to the arthritogenic alpha virus. There exist 3 main genotypes, and the most known is this Central South African genotypes, which have circulated since 2004 and until now, as the recent outbreaks from South America or even in Réunion this year was due to the East Central South African divergent genotype. The Asian genotype caused the outbreak in Latin America and the Caribbean and Latin America in 2014. So let's come back to the Réunion Island epidemic in the Indian Ocean, 2005-2006, where it started. It was formerly known from about 50 years, discovered in Tanzania, but first massive outbreak was observed in Réunion in 2005-2006. Was due to the first massive outbreak due to Aedes albopictus. More 250,000 cases were reported, and about 300,000 people infected. the asymptomatic rate was 70%, more important in children. There were hundreds of hospitalized cases, more than 200 deaths, and excess mortality at peak epidemic, as observed in Brazil and other countries with massive chikungunya outbreaks. And the cost of the epidemic was very huge. In 2005, 2006, we didn't know about the transmission of congenital transmission of arboviruses. We had observed dengue transmission most perinatally or sometimes intrapartum. But it was very case report or case series. We knew that yellow fever or West Nile fever could be transmitted, mostly antepartum for yellow fever and intrapartum for West Nile virus. But we did not observed transmission of alpha viruses. So there were experiments with Geta virus, Milky Forest, or Ross River virus. And we knew that in mice, it could be transmitted during childbirth, during delivery. This time we have developed animal models, mainly mouse models for chikungunya, and we know can be transmitted vertically, especially around the childbirth. And there were two models that were developed at that time. One putting the view on type 1, the critical importance of type 1 interferon in the transmission. And the second in a humanized mice that was developed years after and shows that it can be transmitted also during gestation. So in 2005, 2006, and chikungunya, and the first case were in a dizygotic twins. It was at the 3rd month of the epidemic. Woman present with in the delivery room with acute fetal distress, and the child was delivered. The children were delivered by C-section. One was in apparent death, the boys, and the girl was healthy. Only the boy get infected and developed encephalitis on the 5. And it was the first time we observed a possible vertical transmission. And at that time, we had no means of diagnosis. We have no PCR, no serological serology. So we store the samples and send them to Institut Pasteur in Paris. And by late September, we have recorded 4 similar cases, diagnosed with certitude, and we have developed the PCR and serology. But our local health authorities were doubtful and denied the diagnosis. They didn't believe us it could be transmitted vertically and treat us like the messenger from Antigone. Picture of the epidemic on Réunion Island. We record more than 40 cases, including 38 confirmed cases in 2005, 2006. And in the recent outbreak, we only observed 2 cases. We won't talk about the 2025 outbreak, but we can discuss it after. Well, we observed that the virus was non-teratogenic, no congenital abnormality. There was no higher rates of preterm birth or small for gestational age children. And what we observe is transmission only in peripartum or intrapartum. when the mother is highly viremic, and the transmission rate was about 50% in this situation. We could observe fetal heart abnormalities during labor. What is important to say is that the child, with the exception of acute fetal distress, the child presents no symptom at birth. The symptom develops as far as the viral load grows in his blood and develops symptoms from day 2, day 3, with a peak at day 4. So the neonate is born healthy and become ill 3 to 4 years to 4 days after. It's very important for prevention. Consider. What is important to say is as the transmission is driven by maternal viremia, it increases with the number of cases in the population. So, as the number of mosquito bites increase in women, and situation of vertical transmission is only observed when the epidemic grows. And after, it's not like Zika that can be transmitted during the pregnancy, and we can observe a case of congenital Zika syndrome all through the outbreak and after. It's very different situation, and the number of cases is observed at peak of epidemic or just before. From 2014-2015, chikungunya arrived in Latin America by the north with the Asian genotype from the Caribbean, and by the south from Angola with the East Central South African genotype. So Brazil got infected by the two genotypes. What is important to recall is that Brazil has a 300 larger population than Réunion Island. So with data linkage, linking birth registers and mortality data, that they can observe many more things that we could not observe in Réunion. So they observe association to miscarriage and fetal losses, higher risk for maternal hospitalization, also observed in Colombia, and severe morbidity and EQST, but no increase in mortality, as contrary to dengue during pregnancy. Dengue can increase maternal mortality, no chikungunya. They also observe higher risk for preterm birth and low birth weight, but not for gestational age. So histologically, they observe placental infection, what we did not observe previously in Réunion. Also, fetuses could be infected, but we did not observe placental infection. They observe children with lower Apgar scores, like us, and higher risk for neonatal death. Chikungunya and breastfeeding. Chikungunya can be found in breast milk. We observe, we collect it from the neonatal gastric fluid aspiration, PCR positive, but we did not observe symptoms in children. The virus can be recovered from milk, but this virus cannot infect in vivo cells, which is an evidence from capacity to become infective and replicative in humans or in animal models. So breastfeeding is not contraindicated but during our epidemic, it was postponed until clearance of maternal viremia, but it's still a matter of debate. What has been found years after from Brazil is that breastfeeding by infected dams may confer resistance to challenge in the offspring. So breastfeeding may be protective, potentially protective from a subsequent infection during an epidemic. The case of persisting arthralgia in pregnant women, it's interesting to see that pregnant women are protected against chronic arthralgia as compared to non-pregnant women of similar age, but it is very different according to the trimester of infection, and the shortest duration of persistent arthralgia after delivery is observed when the woman is infected during the third trimester. It means that when the mother is infected with a pH2 cytokine milieu. The case of transplacental transfer for maternal IgG and child protection conduct this study during the chikungunya outbreak, the shimmer study. And you see, placental transfer can be observed since 13 weeks of gestation. That is larger as far as the placenta grows and maximum in the third trimester. It requires at least 1 week post-infection for the production and transfer to the fetus of maternal IgG, which has motivated tocolysis for passive immunization in our context. The transfer is higher in full-term neonates than in preterm neonates, or higher in normal for gestational age than for small gestational age. That means that the persistence of the transplacental IgG is longer in full terms or normal for gestational age. What you see is it can be as long as 24, 13 months. That's far more than 6 or 9 months expected from previous beliefs. And it may confer protection to the infant, but as we did not observe case of infections or symptoms months after the child was born from a seropositive mother. The clinical aspects of chikungunya, neonatal chikungunya, are very similar to the dengue at presentation, with fever, rash, pain, irritability, but rapidly the pain dominates the clinical picture. There is an encephalopathy or encephalitis, which is very frequent. About 13 or 50% of neonatal infected perinatally develop encephalopathy or encephalitis, tackling difficulties, hypotonia, and seizure. And in some cases, there are atypical forms of myocardiopathy, like Kawasaki disease of infant, or other atypical form is the skin bullous eruption, which can be also seen in small infants by postnatal transmission. It can lead to dehydration and severe disease. Encephalitis is mainly observed in the neonatal period in small infants, but also in elderly. It is largely driven by neonatal infections. It is a demyelinating disease affecting the white matter. Sometimes cause encephalomyelitis or transverse myelitis, but it's not observed in neonates for the medulla involvement. What are the outcomes of perinatal infection? Neurocognitive outcomes were studied in Réunion Island about 2 years after birth in a court named Chimère, Chikungunya enfant court. More than 30 children were followed up. The infection was confirmed. We observed at 2 years of age, about 50% had neurodevelopmental delay as assessed by the Brunellesine, which is a similar test than the Bayley-3 scale of the inter-NDA scale for assessing neurodevelopment. The outcome was worst. Children had developed an encephalopathy or an encephalitis at birth, but it was suboptimal in non-encephalopathic children. We observed a sex bias towards male vulnerability. There were two male for one female that had an adverse outcome, developmental outcomes. It was more severe in male than in female. And the effect was observed independently of confounding factors like the maternal social status of the mother, small for gestational age, or the head circumference growth, so independent of gestational age or breastfeeding in some other models. And what we observe in MRI follow-up is the loss of white matter predominantly in the prefrontal cortex. The Chimère court study has been replicated in Brazil in the Rio court with a longer follow-up of 36 months in average. Only 23 children were infected at birth with certitude in this court, but they are important control children, and the outcome is very similar to ours, with 60% of exposed children with a Bayley score IQ less than 1 standard deviation, of whom a third were delayed, low IQ. What is new from this study is that, as contrary than ours, children that were exposed but not infected, that means the mother was infected during pregnancy, the child exposed to the maternal viremia but not developed the disease. That means it was not not positive to IgM or PCR after birth. Just exposure was associated with a lower EQ. But that's a novel findings. They also observe 23% of autism spectrum disorders as screened by the MCHAT. They gave no precision about sex bias. Now the outcome of our study, 16 years post-infection. Our driving hypothesis, the neurocognitive delays that we observe at year 2 were continuing and will be also observed at adolescence. And we already observed slowing of head growth after birth. It's microcephaly of postnatal onset, very different than from congenital Zika that can start during pregnancy and be present and diagnosed at birth, or even months after, but it's very different. Like it's microcephaly by secondary to encephalitis, which occurs perinatally, not antenatally. So we plan to know neurodevelopmental and neurosensory performance and behavior evaluations, and we will check the age growth years after.
I think we have 10 minutes.
We come first results. It's we observe full delays in infected children, needs for rehabilitative support, speech therapist, psychomotrician, physiotherapist, very significant. We observe IV involvement, mainly strabismus. And what is interested is in strabismus is a common feature of maybe a common feature as it can be also found as a pathway in genetic studies from chronic patients. We observe it mainly in neonates, neonatal infection, but it's a general pattern of gene deregulation. We also observe loss of visual acuity in encephalitic children. What is the neurodevelopmental outcomes 15 years after? They have low IQ. It is important is now neurodevelopmental sequelae are fixed and definitive until school age. There can always be plastic neuroplasticity of the brain that can reverse the outcome, neurodevelopmental outcome, and improve it. At 15 years of age, the outcome is definitive. So they have lower IQ, mainly driven by lower verbal communication, lower processing speed. Also, it is not significant in the match study. We have some case of very severe impairment that are observed in encephalitis case. And we have also mild impairment, mild delays in non-encephalitic group. We use to assess the adaptive skills with the Vineland score, and we observe lower adaptive skills of infected children. It's really driven by communication and peer relationships with problems of socialization. We also observe cases of lower adaptive skills in non-encephalitic children. We studied child behavior using the strength and difficulties questionnaire. We did not observe significant total difficulties, but we observed hyperactivity very frequently. It was observed both in encephalitic and non-encephalitic children. What we observe also is it grows. It continues to slowing after birth. That means there is a centile loss of head circumference during growth of the children, with centile loss observed in more than 68% of infected children. In average, 15%. We observe small head in infected children and severe microcephaly in 2. But it is interesting that even in case of non-encephalitis children or non-microcephalic children at birth or soon after, we observe this pattern of slowed, reduced age growth between birth and adolescent, which is significant. So we search for gene signatures in transcriptomic studies of chronic patients, and we also observe less regulated genes of or delayed or equomyelination, postnatal microcephaly, or leukoencephalopathy. That is very intriguing. These are not the gene found in genetic causes of microcephaly, but there are quite important number of genes involved in these processes that could explain this reduced head course.
Sorry, Patrick, if you can go to the conclusion so we can have some time for discussion.
Yes,
Okay. Sorry for this. It's really wonderful.
So yes, Lord. We have case of microcephaly of Congenital said, case of children that are stunted or wasted. And finally, key messages are mother to child vertical transmission occurs during childbirth. Transmission rate is about 50%. In that case, it's encephalitis. Responsible for intellectual disabilities, learning and academic delays. There's prefrontal damage, which causes executive dysfunction in early childhood. So cause adaptive behaviors disorders in adolescence, like in FAST, for example, FAST disorders, fetal alcohol spectrum disorders. There are attention deficit disorders or even hyperactivity. Severe microcephaly as a consequence of encephalitis, so very different than from Zika. Brain growth in children without encephalitis is also impaired. Maternal neonatal chicken infection also affects the height and weight of the children, and ultimately their overall development. That's all. Thank you for your attention. I'm sorry for being long.
Tom Jacobs asked Luis about any kind of antiviral development for dengue. So Luis, you can say something about. You responded directly on the chat.
Well, I already answered him, but yes, there's no currently there's no antiviral drug that is being used and effective on dengue. I was researching on some promising antivirals, mostly at this time in preliminary studies, but there's this most Novemdesivir, which is it's shown promises, especially in adults population, not children studies yet, and that's the only one.
Thank you very much, Luis. Patrick, something about any trial or in vaccines for chikungunya?
Yes. Well, currently leading the phase 4 clinical trial on IXCHIQ, which is a vaccine from Malnelva. The trial started at the peak of the epidemic in April 2055, but was soon tackled by very severe side effects and a case of death in the vaccine population. We chose pragmatic indications for the vaccine because there was no phase 3 trial about the vaccine efficacy. It was only data on immunogenicity, which were promising. There was no correlate of protection beyond correlation in macaque. So we chose very pragmatic indication and to protect the elderly and people with chronic conditions. But in the first week of the vaccination campaigns, we observed very severe large side effects like encephalitis, and a man who deceased, who died from the vaccine. Was a 85 years old man with comorbidities. Dies after 5 days in intensive care. So it was related on media, and it stopped the vaccine campaign.
Okay.
Yeah, there's to the vaccine campaign.
Sarah, you have a question. You are welcome.
Yeah, thank you so much. Just a question about viremia in your women with chikungunya in pregnancy. I may have missed it, but was the height and duration of the viremia prolonged? I may have missed it in your presentation.
It's short-lived. It's not like in Zika. It can be not stored in the placenta. So it's a short-lived viremia in a pregnant woman. So about 1 week or 2.
Okay, so you measured your viremia over a long period of time.
Yeah.
Is that correct? Okay. And secondly, was there a recrudescence of polyarthropathy in the pregnant women, after they had delivered? Did they have a recurrence of their of any polyarthropathy?
Yes, they can have a recover, but in the young pregnant women, the duration of chronic arthralgia and chronic manifestation is shorter than in non-pregnant women of similar age. The persistence of manifestation is driven by age.
Okay. Thank you. Thanks.
So any reason for this, Patrick? You say that in the pregnant women, arthralgia were shorter than in non-pregnant.
Yes.
But is this related to the age?
It may be months, but I think it's maybe because they are younger, or maybe when they to explain that it's shorter in women infected in the 3rd trimester. We just know that the immune milieu changed during pregnancy. It's mainly Th1 driven in 1st and 2nd trimester, and then Th2 driven in the 3rd trimester around birth. So
thank you very much.
Explanation we can have. We know that some pathology are driven by Th2, but not like chikungunya. Maybe influenza in pregnancy or dengue, maybe most severe in 3rd trimester, but not.
Thank you. Any other question? Do you have the idea that what is happening with chikungunya coming into the European countries? Is it going or growing as it was with dengue in other countries?
It has come in Italy. There are 2 outbreaks in Emilia-Romagna in 2007, and in Roma region, in Lazio region in 2017, I guess. Where several little epidemics in France since 2010. So it can affect Southern Europe as far as Aedes albopicus conquers Europe northward. We know that in France it can be found in almost every department, more than 80. Even this is seasonal in France, and highly dependent from imported case from Réunion or French West Indies, or from endemic countries or epidemic countries. But with global warming, chikungunya as dengue maybe become common in Europe, in Southern Europe, especially
Thank you. Do you have you have a cohort of those children that were considered infected? Is this cohort already working?
No.
Still in place? It's finished.
Finished.
Do you think it's any
We are
place for?
we are still in contact with some of the mother and the child.
Do you think it's place for to build a cohort, a multinational?
Yes, it will be interesting. It will be also interesting to gather data with the Brazilian, for instance, the Rio cohort for performing
So good ideas for research.
Individual personal data meta-analysis, for instance.
Wonderful. So I think we are on time. Any other question? Any other burning question?